Hello, everyone. Today we had this little chat with some of my friends who are experts in hair research. I have here Dr. Paulo Müller, who's my friend from Brazil. He lives in Londrina, right? Londrina.
Yes, that's it. Yes.
And you're a faculty of the State University of São Paulo.
São Paulo State University. Yes.
Yes. Mm-hmm.
In our university we have a hair clinic, outpatient clinic for 10 years, and we are trying to do some research as well. So basically working on hair research recently.
And we also have Dr. Sérgio Galván, who will be here shortly. He's in another webinar. He must be very busy with all the hair information he's sending through all the world. So I'll start here, and as soon as Dr. Sérgio appears, I'll include him. So first of all, Paulo, what do you think about frontal fibrosing alopecia? Did you think the prevalence is increasing, or what's your impression in general?
Definitely is increasing. I believe that's probably, I don't know, some years ago, 5-10 years ago, we could have this kind of discussion if it was a new disease or that was under the radar some years ago. But now it's hard to affirm that because it's clearly increasing. And talking to colleagues from other parts of Brazil or other countries, almost everyone has the same perception. When we started our outpatient clinic specialized in hair disorders 10 years ago, we see 1 or 2, 3 patients with frontal fibrosing alopecia, and now it's almost every day. And I believe that maybe colleagues that are not so dedicated to hair disorders probably are seeing frontal fibrosing alopecia in their clinics frequently.
Yes.
So, of course, we don't have precise epidemiological data to affirm, but it's a clear perception. So I believe that almost everybody agrees on that.
Yes, and I'll tell you something, Paulo, I really believe it's underdiagnosed. I'm sure there's...
underdiagnosed today. Yes, nowadays, yes.
I think all the prevalence we know, it's about 1% of the real cases. So
probably.
Yeah, so because, I think the patients, they look for their dermatologist when the thing is really terrible. Let's say years of disease, right? When they're in this chronic state of 5 or 6 years undergoing hair loss, right?
And some patients have so minor clinical symptoms like scaling and erythema, so minor, so easily to miss this diagnosis.
Especially in younger patients, right? The younger they are,
and the harder the diagnosis.
And I feel the dermatologists, they fear making the diagnosis early on because, even the biopsy, sometimes it's not as specific.
And it's hard because, maybe the patient went to your office for, I don't know, a Botox or a skin cancer surgery and receive a diagnosis of a scarring alopecia that she even perceived. So
she never thought of this, and then
and you propose to do a
thinking
biopsy.
of melasma, talking about melasma, and they say, "Oh,
rosacea, maybe." Wait a minute. You need to do a biopsy
here too. Yeah.
Yes.
And one of the things that I'm very impressed is how many patients, they lose their eyebrows and they get the pigmentation there, and they go to the dermatologist's office and they just say, "Oh, what happened to your eyebrow?" "Oh, I used to pluck the hair and it's like this now." And some dermatologists just believe this. Say,
I'm just getting old and it's normal because I'm getting old, so I need to do something. But it's important because some years ago, it seems to me that we missed much more diagnoses that we miss today. But I believe that a lot of patients, as you said, that are, I don't know, treating melasma and other conditions, the facial papules, even without the diagnosis. Yeah.
Exactly. So I'll start a brief introduction of frontal fibrosing alopecia for those who don't know about it, or for dermatologists, just to have a refreshing of the situation. So let me I have 2 computers here. I'm trying to work on both. Okay, so this is Dr. Paulo Müller. He just published a very interesting article. Can you see the screen there, Paulo?
Yes, I can.
Yes, okay. In the JAD about the risk factors in a study. It was just published some months ago, so we'll talk about this. And we also have Sérgio Galván, who joined us shortly. He's in another meeting.
I'm already here, Carlos.
Oh, you're there.
Oh.
Yes.
Excellent.
Good morning to everybody.
Where are you? Okay.
It's my pleasure.
Undercover.
Let me add spotlight. I think we are both here. Let me put you as a co-host. If something happens to my connection, you can go on and assume the hosting there. Hi, Sergio. Good to see you.
Hi.
So let me introduce you to those who still don't know you. Dr. Sérgio Galván, he's the leader of this trichology clinic in Madrid, right? And you have a great team of researchers and surgeons, everything, working alongside, right?
Yes, we're very lucky because we have a very great team of residents, very interested in trichology and hair disorders. And I'm responsible for the Trichology Unit at the Ramón y Cajal Hospital. It's a public hospital in Madrid. And I also direct the Trichology Unit in the private clinic. And we receive a lot of patients with hair disorders. I want to let you know my opinion about the incidence of frontal fibrosing alopecia, because when I was a resident, any patient with frontal fibrosing alopecia was like the rare case 15 years ago, but now it's like a plague. In our experience, it's without doubt the most frequent scarring alopecia nowadays. And I think that the incidence is increasing, and probably this is a relatively new entity, and probably this entity 30 or 40 years ago or did not exist or was really, really rare. I don't know what's your feeling in US, Carlos.
Yes, I have the same feeling. And I say, I was talking to Paulo here, I think it's currently underdiagnosed. So we have a lot of cases, they're walking around, they don't know they have it. And as soon as they get the information about the disease and they will look for their dermatologist, we will see the real incidence. Currently, it's going under the radar. We cannot detect all the cases, but we see it's growing. And one thing that I always like to talk to my residents is, we had some excellent dermatologists in the past. So in the past 30 years, let's say in my service where I graduated in Ribeirão Preto, we had Dr. Bekele, who was an excellent dermatologist. He wrote textbooks and he had the keen eye. He looked at details. So he would never miss this disease, 40 years ago, if it was there. He would look for all the details, all the papules, all the hair loss. So I think it's a disease that is increasing since the 90s, and we're now understanding it better. So let me continue my presentation here. It's only an introduction. I want to talk about the details of your recent articles. So Sergio, this article that is, can you see the screen there?
Yes.
From 2014, when I first read that article, I said, oh my God, finally an article with a lot of patients. Because before that, it was like, 20 patients, 40 patients. I was, So that was a good review of that you were the first author, and now Sergio just and also this one was an interesting article too that you wrote about the diagnosis criteria to help us in the clinic. I would say you went over the major clinical signs here and to make it very logical for us to make the diagnosis, because before it was like, it's like a pattern like in planus pilaris, so we need the biopsy confirmation. So you see there's the clinical criteria, which is very important, right?
Yes, absolutely, Carlos. And this article, the objective was to share our experience in making the diagnosis without biopsy. Biopsy, in our experience, is almost never required with these other criteria, mainly these clinical criteria and trichoscopic features, which are very clear in the majority of patients with frontal fibrosing alopecia. And with this criteria, we can diagnose early cases of frontal fibrosing alopecia even without scalp involvement, because we evaluate a lot of patients with diffuse bilateral eyebrow alopecia, with facial papules, with body hair loss, that in the past we couldn't diagnose with frontal fibrosing alopecia, but during the follow-up, we observed the scalp involvement. And then I think that these patients benefit from the early treatment with systemic therapy.
Yes. And I say this is the key message here for the whole webinar, is just to make the early diagnosis so we can preserve hair, keep as many terminal hair we can in our patients. So we need to do the diagnosis very early. And just to remind here, this diagnosis criteria, which I like to think about that. There's this two major criteria. If the patient have these two major criteria, the clinical diagnosis can be made, which is just the typical pattern hair loss, and also the eyebrow, the diffuse bilateral eyebrow thinning. But then if they don't have both criteria, you can have one of the major criteria and then have two minor criteria, which include also the biopsy changes and the papules that we see on the face, the other signs, right? And well, and Dr. Galván recently published this article about the effectiveness of Dutastride, which is something that has been we've been talking about a lot in the last years, and I think this is a consolidation of all the knowledge. And with a nice, was this I study a PhD thesis or something there?
Yes, this was the PhD project of Dr. Cristina Pindado, a former resident of my service. And this confirms our view about the effectiveness of Dutastride in frontal fibrosing alopecia, which is something very curious because we don't know the exact mechanism of action of this drug in frontal fibrosing alopecia, but the truth is that the patients that we treated with oral Dutastride achieved stabilization in a higher percentage than the patients that we treated with hydroxychloroquine or other systemic therapies. And this paper shows the long-term results with this treatment compared with other systemic therapies and no treatment.
Yes. And I'll tell you something that I like to joke about the current status of COVID-19 is that, you know, the hydroxychloroquine was initially the drug of COVID-19, and the recent research that I've been trying to help the world to understand, and also, you know, Dr. Andy Goren, we have a clinical trial going on with Dutastride for men in Brazil. And it's funny how medicine, we have these medications that you can use for many things. They are not only for prostate hyperplasia or for lupus or for malaria, right? You can use medications to help the patients in other realms. So I'll do a little brief. So for those who don't know about the history of frontal fibrosing alopecia, there was this first little article that came out in the archives, which is now called the JAMA Dermatology, in 1994. And they mentioned, oh, there's this pattern in distribution, looks like lichen planus pilaris. That article didn't make much noise, but then there was another article. But actually, you know, in the same journal, there's been this year, one article remembering the clinical signs and everything, you know, after 26 years, showing an illustration of a case with papules on the face and the typical pattern. So nowadays, this picture, every single dermatologist understands what's this disease, while 26 years, that little article, no one even looked at it. But anyways, Cossard, who was from Australia, he published another article which made some more noise, which was a more solid article. He really described all the histological changes and the clinical changes. And he, back then, in 97, he thought this was a disease of postmenopausal women, right? It was like a description of all these women that had this clinical signs. And we know, what do you think? Do you think it's a disease of postmenopausal women nowadays?
Not only. The
Not
incidence in premenopausal women has increased also.
Yes, it's, but certainly more prevalent in women, right? Certainly.
Yes.
But then, of course, after menopause, it seems that the disease just flourishes, right? It shows all of its signs, and curiously, after menopause is also when they start having more signs of virilism, more mustache. That's usually the age that women start losing more hair, and they lose their protection of the estrogens, right? So they start presenting more male symptoms. And anyway, so he described this inflammation that was around the follicles, especially in the infundibulum, in the funnel of the follicle. And he didn't see any inflammation in the epidermis. He was saying that it was a lichenoid inflammation in the infundibulum. And anyways, we know nowadays that the inflammation can also happen in the epidermis if the patient has lichen planus or they have other signs. You know, the skin is becoming dark, lichen planus pigmentosum. So the skin always reflects the histopathology, right? We can almost predict if the skin is normal, the epidermis will be normal, right? We're looking for deeper things in the follicles. Anyway, so I brought this picture just to show that what's the isthmus or the hair. I said infundibulum. The isthmus, which is where the hair thins. So in the root, it's thicker, then it becomes thin, and then around the infundibulum and around the surface, it thickens again. So there's this isthmus, this part of the hair that the hair is actually thinner, tighter. And that's where the inflammation occurs. I said infundibulum, but it's the isthmus. And what's interesting is that exactly in that area, we have the stem cells. We have the bulge, which is the origin of the skin. It comes in these little sites there. And the inflammation is there and destroying the hair. So about pathology, histopathology, now we know there's some genetics, hormonal changes, maybe it's autoimmune, and now the environmental factors, which we're starting to consider them more. So let's go talk a little bit about some environmental factors or what we think could be attributed as a trigger or like an association. So there's been many articles about the subject, and Dr. Paulo Müller just published a good article there. Can you talk a little bit more about the risk factors or environmental factors, Paulo?
Yeah, so it's a very complex and contentious topic for sure. And of course, that this rising incidence raised this idea of environmental factors in frontal fibrosing alopecia. I do believe that there is a genetic background, but probably we have external factors contributing to or triggering the disease. We have some case control studies showing association of frontal fibrosing alopecia, especially with sunscreens. And so now I believe that the question is just a association or there is a causal relationship, because it's different. And with case control studies, we can establish a cause relation, but just associations. And if there is really a cause relationship with sunscreens, which ingredient would be the culprit? So it's a good discussion as well. So we performed this study in Brazil with a lot of colleagues and hair experts all over the country. It was a work with many colleagues and friends. And it was a little bit different because we could evaluate a multiracial population, so different from previous ones in Europe. Sérgio made a very beautiful study in Spain. We had other two studies from England and another one from Professor Sinclair from Australia. We couldn't see this relation with the use of sunscreens like in the other ones, but with moisturizers. And we could find a kind of a surprise, a negative relation with smoking. It was a surprise, but not a surprise at all. Previously, the Sérgio's group showed the relation of smoking with milder cases of frontal fibrosing alopecia comparing to non-smokers. We don't know how exactly that may occur. Maybe, I don't know, cigarette contains thousands of substances, maybe shifting the inflammation from, I don't know, TH1 to TH2. But I believe that we must be aware about this information. It's hard to really advise patients based on that, so we could really discuss about it because it's a challenge. And I really need to discuss how to move forward, because it seems to me case control studies were important. They brought some information, they shed some light, but raised a lot of new questions as well. And I really don't know how we can move forward in the understanding of frontal fibrosing alopecia. I was talking to Sérgio recently about it, and I believe that's a good point of discussion.
Yes, one thing that the first thing I saw in your articles was actually the formalin, the hair straighteners,
yes,
which we know in Brazil it's
very
even though
popular.
It's prohibited
Yes.
by the government. We know people do it, and somehow, you know, yeah, it makes sense. You know, formalin is very aggressive and can change even DNA. It can cause cancer, all those things. That's why it's even prohibited, right? So,
and the case control study that Sérgio published, they found a relation with alkyphenols in their study. So maybe kind of a relation between the two studies. One point is, of course, that the straightening occurs in all the hair scalp, not only in the frontal scalp. So it's still a little bit hard to put all those informations together. But
yes,
that makes sense, and probably we could see that because here in Brazil is extremely common, as you said.
Yeah. So let me show some other. There were some studies talking about titanium, right? Because it's basically it was the first pinpoint of the sunscreen issue. When they studied hair, plucking hair, they were looking for things that were attached to the hair shaft, and then they found titanium there, which we know it's related to sunscreens and also some products that we use on the face. You know, titanium is all over in our toothpaste. It's white. The thing is that titanium reflects light so well, it makes everything white. So they add titanium actually so the creams look beautiful and shiny. And even though it seems to be very inert, so it doesn't react. We have titanium plates, you know, for orthopedic surgeons, they put titanium pins. It seems to be very safe, but also it changes the reflection of light. So it creates like a mirror effect in the hair shaft, and then when sun's shining, it can reflect more light, which can impact the stem cells there. Who knows? So, and there were other studies confirming the same finding, and let's say when they looked for a man or one patient that didn't have alopecia and was not using sunscreens, they didn't find it there. So we still don't know how titanium relates exactly to the whole picture. But one thing that I find interesting is that we can, you know, everything we put topically in our skin, usually our skin has this protection. Things don't get in the hair follicle that easily. So depending on what's around the metal, around the titanium, there's some substances which can make actually the metal go down the follicle. And, you know, there's no way of chasing for that in all the sunscreens we have. Each one is different. It's like crazy. There's no way of doing a study like that unless we had a model in mouse, which you could test every little details. So things get inside the follicle somehow. And there was this study from Andrew Messenger's group, which I found very interesting the first time I read, because it also pointed out to some allergens like linalool. They had like 40 patients with frontal fibrosing alopecia, and basically 1/4 of them had a patch test, a positive patch test to one ingredient, linalool. So that's way over what we would expect. 25% of sensitivization to one ingredient, that's a lot. So maybe there's also some allergies, and there's this, maybe compared to controls, frontal fibrosing alopecia patients, they use more sunscreen, but also more moisturizers because their skin is more dry. So anyways, there's so much to learn, right? And this last articles of this year, they were discussing this question about sunscreen. So we had 2 or 3 articles in the JAD this year just discussing this issue about what's a safe sunscreen, what we consider like a review, or maybe it doesn't impact, we still don't know. And there was this group that made a survey among hair specialists, and when I read their article, I said, oh, great. It was published now in October of last year. I said, many hair specialists are thinking like me. They're thinking, oh, we have to maybe hold some ingredients, use safer ones. And I recently heard a webinar from Sergio's group that they were saying about the same rationale, that avobenzone is absorbed, it can go through the body, and while titanium stays in some areas. So maybe the patients that have more systemic involvement, we start to think of a relation with avobenzone, oxybenzone, maybe, while maybe more localized in the face, who knows? But I personally have been trying to, when I have a patient with frontal fibrosing alopecia, I tell them, we still don't know about all this information, but there are some other sunscreens which we assume they are safer, like with zinc oxide and also with iron oxide. Who knows? I prefer to keep them safe. What do you say about sunscreen, Paulo and Sergio?
It's very hard to say, and it's interesting because when I try to share this information with patients, it's not easy for us, even more for patients, but I try to explain to them what we have now. And sometimes I see that some patients are so terrified with the idea of losing their hair permanently, and they try to do all that they can. So they stop immediately using sunscreens. And in those situations, I really try to reinforce other measures of sun protection. But generally, I explain, I start treating, and in a second step, if the treatment is not so good and the results are not the way we expect, I try sometimes to stop using sunscreens and see how it goes. We have some cases in the literature with good response after stop sunscreens. Of course, it's just 1 or 2 cases, but I took that in consideration because probably we're going to talk about treatment after, and it's hard to treat frontal fibrosing alopecia. Some patients do not respond to treatment, so sometimes I try to stop using sunscreens. But of course, I do believe that it can't be a general. You can't advise for everybody or try to. If we stop using sunscreens, we would avoid frontal fibrosing alopecia from now on. So certainly we don't have data to make this kind of.
It's too cloudy. And Sergio, how do you recommend to your patients? Let's say a new patient came to your office today. She thought she had melasma, and she was using sunscreen. She needs sunscreen, and they say, "Hey, wait a minute. This pigmentation of your skin can be like in planus pigmentosum, and you see this part." What would you tell them?
Well, I completely agree with Paulo. I think that there's not enough scientific evidence yet to avoid sunscreens in every patient with frontal fibrosing alopecia. But I tell to my patients that this is a controversial issue under research, and in patients that are not responding well to the therapy, and in patients that we treat with oral Dutastride, topical anti-inflammatory treatments, and besides this, despite this, the patient worsens. In these cases, we consider to minimize the use of sunscreens and to recommend physical protection. But I think that this is probably one of the most controversial hot topics now in trichology, and in the next years we will have more responses.
Yes, exactly. Well, I personally tell them, well, assuming that the ones that the hair specialists they usually point out when they point out is titanium and also avobenzone. Let's try to use the other things for now until we have more information. Maybe things can change. Who knows? In 10 years, we'll be pointing at zinc. Who knows? But currently, you know, I'm a fan of zinc. I'll tell you this. Zinc, a lot of zinc ointments for healing. Just like diaper rashes and all those things, they're all zinc based. Okay, so let's move forward. So talking about environmental factors and how our skin can actually absorb some metals, we know that there's this disease that can happen in some areas which have a lot of volcanic ashes, like in Ethiopia, some parts of Brazil too, that, you know, some metals from the dirt, they can go in the skin and create this lymphatic podoconiosis here. So anyways, metals, they can kind of penetrate our skin and go to the lymphatics, who knows? And well, now let's talk about the current therapy. So about Dutastride, this article that Dr. Galván just published, I think it makes sense to think of Dutastride as it might have some immune regulatory effects, but also we know that it prevents miniaturization of hair, right? That's key. Like we try to make less vellus hair. Because I don't know if you agree with me, but it seems that vellus hair are the ones that are really destroyed by this disease, right? It seems that they are more superficial maybe. So the body, when patients have frontal fibrosing alopecia, it seems that the disease is looking for vellus hair, chasing them, and then it creates this little papules, all those things. And well, and what, so a little slide here about the miniaturization. We know that DHT is the main hormone that triggers this, but we don't know exactly how DHT does that. Maybe it's through cytokines, IL-6, for example. Something happens there. DHT is just, it pushes the button, but then what happens afterwards, we don't completely understand. But we know that DHT can make a lot of hair turn very thin. They become this vellus hair, this phenomenon that we call miniaturization. And we know there's also some microbiome, some mites that like to eat some hair. They also like to eat vellus hair. They're in the skin, sometimes in the frontal scalp. We don't understand this very well. And just to remember, this was the first article that kind of triggered Dutastride research. When I saw this article for the first time, I was amazed. I was like, oh my goodness, how did they make this eyebrow grow? I never seen this in many years of practice, growing so much with Dutastride. And there was another article in 2013. There was a series of cases, 19 cases only, from Duke, that they really found out that Dutastride was kind of the main drug that induced more remission or stabilization of the cases. And I remember I was in 2013 when this came out. We discussed this in the grand rounds at Harvard. I was with Dr. Harley Haynes there, and we had a very good discussion about the use of Dutastride and if it's safe or not in females. because of teratogenicity and all the things. Anyways, but I wanted to have a word from Dr. Galván. Do you think, is it your first therapy, or do you try something else before? How do you go?
Well,
What's your approach?
when I started in the heart disorders consultation, I received a lot of patients with frontal fibrosing alopecia at Ramón Cajal Hospital, and my first line treatment was oral hydroxychloroquine. I'm talking about 2010, and I obtained very bad results in terms of safety of the drug. Many patients had to stop the treatment, and in terms of effectiveness, the majority of my patients worsened over time. And when I saw the article of the group of Dr. Olsen about Dutastride, I started using Dutastride in almost every patient. And I observed a higher percentage of stabilization with this treatment. And currently, this is my first line treatment for patients with frontal fibrosing alopecia. And if I see intense signs of inflammation on trichoscopy, I consider using and combining oral hydroxychloroquine. But my first line is without doubts oral Dutastride. And in the recently published article, we saw that the percentage of stabilized patients are higher compared to other treatments. I don't know if Paulo has the same experience.
Yes, exactly the same. We started our hair clinic in 2010 as well. And back then, I just saw frontal fibrosing alopecia as a kind of LPP. So because of that, hydroxychloroquine would be the most obvious treatment. But in my opinion, hydroxychloroquine isolated, the response is not good, not at all. So sometimes when the patient has a lot of inflammation, so I see a lot of scaling and erythema. So I try to use these anti-inflammatory properties of hydroxychloroquine, but always along with Dutasteride or even Finasteride. So 5-alpha reductase are my first choice. Dutasteride, if sometimes it's a little bit expensive for some patients, so I go with Finasteride. We can use, Sergio can talk a little bit more about it because Dutasteride has a long half-life. For some patients, they may take 2 or 3 pills per tablets per week, so it's an option. But I always try to use Dutasteride today. So in the last years, I've been doing it this way, almost like Sergio.
Yes, and one thing to keep, yeah, I agree. I try to start Dutastride as when I can. That's the key, because there's some female patients who are still in childbearing age.
Yes,
they still can get pregnant. So I would never start Dutastride in those patients unless they had intrauterine device and really agree to stay. It would be like starting acitretin, which has a long half-life. Yes. I try my best not to use it. So in females who need acitretin, I go for Isotretinoin. With the same thing with Dutastride. Females who can have kids, I go for Finasteride, 5 milligrams. And because Finasteride, if they stop it, they can get pregnant in the next month, just like Accutane. While Dutastride, they have to stay under birth control for 6 months. And that's a high risk for them.
Yeah, I think, Carlos, this is a very important issue, but in our experience, the premenopausal women with frontal fibrosing alopecia that we receive are in their early 40s, and they have already had children, and they are not looking for pregnancy. But it's true that for androgenetic alopecia, these female patients in their 20s, we prefer not to use Dutastride in these patients for this reason.
Yes, exactly. And I also think Dutastride is the main medication actually for all the miniaturization. So when we see any patient with miniaturization, male pattern, it is the medication that we know that has the most powerful effect to avoid new miniaturization, right? So I try to use it as much as I can, even for younger men. But anyways, so about the the inflammation, I think the Dutastride also has some effect on inflammation, but it's not as powerful as the other agents. But do you use topical super potent corticosteroids, even when they have a thinning of the face? We use clobetasol, or
I prefer to avoid topical steroids in frontal fibrosing alopecia patients, and I use topical calcineurin inhibitors, mainly Imecrolimus, because it's marketed in Spain as a cream, and I prefer not to use steroids in these patients.
Yeah, I agree. Me too. First, because it can do some rosacea, and usually the patients they have the thin skin. I don't want to risk having more atrophy, so I try my best to avoid it too. And going on with the discussion, let me go back to the slide. Sorry, was this the last slide? Yes. So yeah, that was fast. But talking about isotretinoin, so
Yeah.
I wanted to get to that point, because I personally believe that isotretinoin has this powerful anti-inflammatory effect. So I use it in patients who have post-inflammatory hyperpigmentation. I use in any signs of rosacea. It is a powerful anti-inflammatory drug. And we know it's very powerful to reduce the papules, right? But do you use it only for papules, or do you also try to use it when they have erythema, perifollicular erythema? What's your impression?
It's interesting because for facial papules, it's extremely useful. And I believe that it's the situation that we get the best results in frontal fibrosing alopecia is we can almost always resolve facial papules with isotretinoin. We have the study of Professor Rudnicka showing very good results in the hairline. But honestly, I can't see these good results in the frontal fibrosing alopecia progression when it comes to the hairline or even inflammation. So today, I know that's very controversial as well, but today, if the patient presents facial papules and it's bothering the patient, I certainly will use isotretinoin. But for the hairlines, just if I can get good results with other treatments, so I try isotretinoin, but my experience is not so good. What do you think, Sergio and Carlos? What's your experience with isotretinoin?
Yes, I completely agree with you, Paulo. I think that this drug is very useful for improving facial papules, but I have not had a good experience in achieving a stabilization of the hairline with medium or even high doses of isotretinoin. I think that it's also a very bad tolerated treatment with medium or high doses to think about maintaining it in the long term in patients that will have to make a treatment for several years. There was a question about the safety of Dutastride. In our experience, it's a really safe treatment. We didn't see any significant adverse effect. We didn't have to stop the treatment in any of the 224 patients of the study. So I think this is a very interesting treatment as a maintenance therapy.
Yes. And Carlos, just thinking, because I've never used acitretin to frontal fibrosing alopecia, just isotretinoin. They are similar, but not the same. So what's your experience with acitretin specifically, both you and Sergio? I've never used it in this situation of frontal fibrosing alopecia.
Yes, I think, acitretin, we have more issues regarding drinking and liver issues. So I try my best not to use acitretin anymore, even for psoriasis. It's one of those medications that it's back on my list nowadays, and I try to use isotretinoin. If the patient has any side effect, if we stop isotretinoin, the next month they are better. So I try to avoid that. But I personally, I think I used in about 10 cases maximum at low dose acitretin, like 10 milligrams. I didn't see much improvement in inflammation. And that's interesting because sometimes the right dose, let's say the first article published about frontal fibrosing alopecia, they try to use 50 milligrams of isotretinoin per day, which is a very high dose. And they said, oh, the patients didn't improve. They still had peeling of, but currently we are seeing lower doses of isotretinoin making more effects, like 10 milligrams per day instead of higher doses. And so I try to use as lower dose as possible. So the patients, they don't have any cracked lips, only the effects of vitamin A without any overdose. You know, I try to stay in the anti-inflammatory effects, which is low dose. And there are some questions here. Let me see. I'll go over the questions. I didn't even see them. Sorry. So there was a question. Oh, okay. Jennifer Barnes asked about sunscreen with zinc oxide. Yes, I went over that. Yes, I try to go for zinc oxide. The problem with zinc oxide is the sunscreen is usually white. Even the micronized zinc, it's not perfect. So you have to combine with other things that make it more skin color-like, which is iron oxide, melanin. There's other ingredients in the sunscreens that I look for when I try to use physical sunscreen. Which, by the way, for melasma patients and these patients with lichen planus pigmentosus, I really think iron oxide is a prerequisite of my sunscreens. I don't prescribe any other ones. I see much better effects. We had that question that I think Sergio just answered about the safety of the Dutastride regarding, yeah, we went over that. Oh, we have Elena, is that Elena Kuhn? Is that who answered that? Do you use Dutastride in women who have had breast cancer? What's your opinion? What's your
Well, although there is some scientific evidence published supporting the use of Dutastride in female patients that have a personal history of breast cancer to prevent a second cancer, and there are some references in PubMed, it's true that the majority of patients have heard about the negative effect of these drugs regarding breast cancer, so we prefer to avoid them. And in these patients, we can use other anti-androgenic drug, specifically oral spironolactone, that has been recently published its safety in this profile of patients.
Mm-hmm. Yes. Well, I personally, I tell my patients, you know, there is no evidence that Dutastride can increase breast cancer, but, you know, I'll ask for the opinion of your breast specialist. If they say it's safe, I'll prescribe. If they don't like it, if they prefer not to use it, then I will avoid. So I'll tell them that. And they agree, you know, I think we should always talk between the specialties. But my personal opinion is that it's completely safe. And even for prostate cancer, I really believe it's completely safe. But I also check with the urologists. And let me see other questions here. Works for, how do you think that the Dutastride only works for FFA? How about other types of scarring alopecia?
Well, for some scarring alopecias in which androgens are also implicated, for example, in fibrosing alopecia in a pattern distribution, I also use the Dutastride, but for sure not in lichen planopilaris or folliculitis decalvans.
Mm-hmm. Yes, I think we still have a lot to learn about the impacts of DHT in the whole, even for infections, even for coronavirus. We're learning about that. Do you find it hard to have patients comply with topical calcineurin inhibitors since the cream and ointment made it harder to style the hair? Do you try to get it compounded as a solution? What do you do, Sergio?
Well, we use the cream because it's cheap here in Spain. The ointment is impossible. The ointment is impossible to use, and if we get compounded as a solution, it's very expensive. So we use topical pimecrolimus in cream once or twice weekly.
Mm-hmm. And resistant cases of
just to avoid the frontal area of the frontal sunscreen, probably. Yeah.
Oh,
Yeah,
to use the sunscreen in the rest of the
kind
face.
of avoid the frontal hairline, maybe, I don't know, 2 or 3 centimeters away from the hairline. So some colleagues advise that. Yeah, maybe it's a strategy. We don't know how much of that is absorbed, but nobody knows for sure. So maybe for some patients that really have a lot of outdoors activity, it may be an option using a hat and avoid the hairline. We don't know how much effective it could be, but it's an idea. I don't know if that's the question, but I think so.
Yeah. So I always tell my patients to protect themselves from the sun. I really think the vellus hair, they're more superficial. And if they get a sunburn where they have vellus hair, frontal fibrosing alopecia will kill the hair. But most importantly, the sun will kill the vellus hair. I really believe that photoaging is the final hit of all alopecias. So let's say if men with AGA, they didn't have photoaging in the scalp, it would be easier to rescue them. So the hair starts to thin, and then they go to the sun, and the sun is the final hammer blow in the little tiny hair that is there, and then the bulge gets a mutation and is killed by the body. So I think it's very important to protect every little piece of hair, especially where the hair is thin. Okay,
I have a question, Carlos, for you that I think it's very interesting because in the US it's not trendy at all, but here in Spain and I think in Brazil we use in some selected patients the option of hair transplantation for our frontal fibrosing alopecia patients. And I wanted to know your opinions about this issue.
Yes, that's a hard question. Well, I really believe, hair transplantation, when it gets to hair transplantation, it means that's the only step you can do. There's nothing else, or just use a prosthesis or something. So I believe it's harder to get the transplant to survive, but I think it's worth trying. And you can only know the results after trying. That's why what I always tell my patients, we can talk about all the theory here, but what's really important is the experience. If you try, you'll see if it works for you. But I think the stem cells, when you do a transplant of hair, you grow new stem cells there, which can help. Just like when we inject fat in some areas that are atrophic from lupus, for example, I think stem cells, they help the skin. And what's your impression, Sergio, about hair transplant?
Paulo, do you want to comment something before?
No, it's very interesting because when I saw your numbers from your study, when you presented in our last meeting, the survival rate is 40% in 5 years. Is that?
Yes.
So it's interesting because some colleagues, whoa, that's great. So 40% in 5 years, we have to try. And other ones, oh my God, it's awful. 40% in 5 years, no way, I will never do surgery in this kind of patients. So it's interesting because you really need to explain patients, because I believe that when you have a hair transplant, you really hope that the results, it's gonna be, I wouldn't say forever, but long-lasting results with surgery. And we can affirm that. But on the other hand, these patients do not have any other possibility to get her hair back.
Exactly.
So you need to explain, but you definitely must be aware about what you're doing and the survival rate, because many surgeries have been done with no diagnosis. Just let's put hair on this area and that's okay. And that's a problem because many patients, especially those that are not treating, probably gonna lose their hair.
Yes, absolutely. I think that it's very important to manage the expectations of the patients and to explain the durability of the drugs in the long term, despite receiving medical treatment. But in my experience, it's a very useful treatment for the sideburns, especially in female patients. But we have to stabilize the disease before thinking about hair transplantation.
Yes, exactly. The inflammation, we cannot see inflammation and just transplant hair in the middle of the inflammation. That makes perfect sense. So I'll go over some other questions here about ILK, or intralesional triamcinolone. Do you use it in the beginning? How do you do, or prefer topicals? What's your impression?
Yeah, I use intralesional triamcinolone only in cases that are worsening, and if they have inflammatory signs on trichoscopy, and I use very diluted 4 milligram per milliliter triamcinolone.
Yes, I agree. It should be extremely diluted. I think compared to alopecia areata, the patients, they have much more atrophy, much more atrophy. Do you agree? If you go 10 milligrams or 7.5, usually they have atrophy. That's my impression. I try to go with the lower concentration I can. And personally, I'll tell you, over the past 5 years, I've been trying to avoid the injections of triamcinolone. I've been using it with the tattoo machine. The microinfusion of drugs through the skin that, you know, in Brazil, it's very common. Most dermatologists have a tattoo machine. Do you use a tattoo machine there, Paulo?
No, in frontal fibrosing alopecia, not. Maybe I should try. I'm not a fond of intralesional therapy for frontal fibrosing alopecia, but sometimes we had to try, especially for those patients with a lot of inflammation. But I generally see some kind of atrophy. Just minimal, maybe it doesn't take so long to recover, but even with diluted doses, you may see that. So we must be extremely careful. And in the eyebrows as well, because I saw some terrible results in the eyebrow. So yes, we must be careful with
very dilute. And yes, I agree. So the reason why I moved to the tattoo machine is that I've never seen a single case of atrophy with the tattoo machine. Even when we get the 40% solution, because the amount that gets through the skin is minimal. So that's my preferred. If I see any hair with inflammation, I say, oh, let's just tattoo triamcinolone. And okay, we have another question here. Do you think for androgenetic alopecia, do you think Dutastride is better than Finasteride for females?
Well, this statement is not as clear as in male patients, which for sure Dutastride is more effective. But I have also better experience with Dutastride compared to Finasteride in female androgenetic alopecia.
Yeah, me too. I agree.
Yeah.
What do you say, Paulo? Same?
Yes, the same.
We have a question from John Kulesa here. What about topical retinoic acid? Do you think it could be useful?
Not in my experience for FFA patients.
Yes, I don't. I try to avoid topical. So when I use a retinoid, I prefer to use it by mouth to improve the inflammation better. And okay, PRP. What's your thought of PRP on this?
Well, I have had very great experiences with PRP in cicatricial alopecias in the last 2 or 3 years, especially in lichen planopilaris. And we are starting using this treatment in frontal fibrosing alopecia patients. And I think that it has a slight anti-inflammatory effect, and it can improve the atrophy of the skin in the hairline of the patients. And I don't use for every patient, but I use PRP for selected patients here.
Yes, I agree. I kind of think of PRP in the same rationale of microneedling, trying to get some stimulation of the internal mechanisms, improve the atrophy, try to recruit more blood flow and restore health. Well,
we have not talked about oral minoxidil, but it's another interesting option for FFA patients as well.
Good that you Is Elena Kuhn still here? Let me see. Are you here, Elena? Let me see. I don't know if Elena left. So Elena Kuhn, she's the director of the hair clinic here at Brown, and she just gave a lecture in the NEDS about oral minoxidil. Yes, great to remember. What's your approach? Yes, I try to start as soon as possible. I think oral minoxidil really can change the game, improve try to reverse the miniaturization. I think that's very helpful. What's your impression? And I'll tell you, I usually use higher doses than I've been reading on your articles, Sergio. So I go 2.5 at least. And what's your impression, Paulo?
Yes, it's interesting because I've been using oral minoxidil for a while, but I wasn't so helpful with the results in cicatricial alopecia. And some years ago, I learned from Sérgio in one of his talks, and I started using. And I believe that as an adjuvant treatment, they publish a very beautiful article in Lycoplanus pilaris as well as an adjuvant treatment. And of course, it's not the main treatment, but it could be extremely helpful in some areas that we can see some partial regrowth with oral minoxidil. And it seems to me that hypertrichosis is not a big deal in patients with frontal fibrosing alopecia, probably because of that you can use higher doses than we generally use in androgenetic alopecia. So yes, it's interesting, and I try to use it, and it's pretty easy to use. There is no generally big problems with other treatments that we use along in frontal fibrosing alopecia, so it's very easy to combine treatments. Sometimes it's hard to apply topical minoxidil, especially in the hairline. So it's a great option. And I'm trying to use almost in all cicatricial alopecias as an adjuvant treatment. So it could be certainly helpful.
Yes, yes. I think oral minoxidil really changed the game in the last years. And we had to be very thankful of the hair specialists in the world that have been studying that and using it. And another thing here, I think, for JAK inhibitors and frontal fibrosing alopecia, I think that's the new frontier of. So I've had some patients who used it. Well, the key thing here is to try to start therapy early on, right? When they have inflammation, they're not in this chronic state where they don't have any more reserve, any more hair left. When that's the case, that's the surgery part only. So, but my experience with JAK inhibitors is that inflammation is reduced drastically in the first month of therapy. But as I said before, my personal preference for anti-inflammatory drug is isotretinoin, but I would consider along the therapy if the inflammation is not improving, and even with the topical calcineurin inhibitors, I wouldn't go for, let's say, cyclosporine. I would go for JAK inhibitors. But what's your thoughts about the future?
Yes, probably JAK inhibitors are the new best research in the future for frontal fibrosing alopecia. I think that it will be another interesting anti-inflammatory treatment.
Mm-hmm. Yes. And okay, just to finalize here, we have some other questions about oral minoxidil plus Dutastride simultaneously. Yes, that's the thing. So you use both together. And okay, topical spironolactone.
No experience.
No, me too. I never had any experience.
Never used it.
Yes. And what about other topical anti-androgens? Like, flutamide back in the day, or something else about the androgen thing is that I don't know if anyone has ever studied androgen blocking agents, bicalutamide. Have you ever tried bicalutamide for frontal fibrosing alopecia, Sergio?
Not yet, but looking forward to it.
Yeah, that's another new frontier. I think that's a good option for female partner hair loss, and also for hirsutism. But I think the world has to still experience those.
Let me make a comment, Carlos. I think that as dermatologists, we should focus not only on the medical therapy, but also on the cosmetic improvement. For example, patients that come to our consultation, female patients with a complete eyebrow loss, I, in the first visit, recommend to undergo micropigmentation or microblading, because the cosmetic improvement that these female patients will get is really high. So I think that we should open our minds and not only think about medical therapies, but also in these cosmetic options.
Yes, I completely agree. I think we have to treat from all perspectives, their mental health, give the right support, and you know, sunscreen, everything. We try to improve their well-being, and I agree. If they need some microblading, yes. Okay, so I think we can conclude now. I think it was a little over the expected 30 minutes, but I think it was a very comprehensive, up-to-date meeting. I really, thank you for accepting the invitation. I think this will be very helpful for dermatologists, maybe for patients too, but the main idea was to update the dermatologist. Do you have any final comments?
Now, congratulations, Carlos, for this project and this webinar. I think it's very useful to share our experience with this easy way. In this 2020, we have to adapt with these webinars, and hopefully in next year we will meet face to face again.
Yes, and thank you, Paulo. Any last words, Paulo?
Yes, my pleasure. Thank you so much for the invitation. Great discussion. Thank you so much. Really looking forward to seeing you again. I hope in 2021, probably nobody knows, but I hope so. And it was a pleasure. Congrats, Carlos. A great discussion. Yeah. Thanks so much.
I hope to see you in person in San Francisco if the AAD meeting happens.
Yeah.
For sure.
Okay. Thank you very much.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.